It's not easy. I've got a lot of arrows in my back over the years of doing this from lots of other professionals. On the flip side, I have a lot more referrals from pediatricians and from ENTs and people who are saying, the families are coming back with positive changes. We don't know what you did, but tell us. So we get that. I've had it from my own colleagues in my field, people that have trained me. I've shared a story before. One of my mentors who was a chief of my residency training program, who was very arrogant and whatnot, his daughter had a baby. Baby had breastfeeding problems. Lactation consultant gave him my name. He's like, have you heard of this guy? He's like, yeah, he was one of my residents. Came in, he's like, I have no idea about this. I'm talking to you now as the teacher. You teach me. It's like, it's a very humbling experience because we don't get any of this. And you guys are all in that unique position. So, what are the potential problems? We keep talking about. Everybody's going to be repeating this. We start from the earliest time, infant feeding. We see breast and bottle feeding difficulties. So I get them coming from lactation consultants. I get them coming from feeding therapists. I get them coming from all different, areas. We see a lot of kids, looking at, as they're growing and developing, the kids that are labeled or given a diagnosis of ADHD, but they're actually not sleeping well at night. And that's coming out during the day. You talk about Sydney's story. She's a classic case of things with an airway and all of these things that we miss. So when you start going down these checklists and I start doing a consultation with a family, the majority of my time is not spent looking at, there's a tie, let's treat it. We talk about what's going on. Tell me your story. Because mom's instincts or the family's instincts are usually right. I would say that, if that mommy thing is going off in your head and your doc is saying everything's fine, they're on the growth charts, they're fine, they're gaining weight. But how are they gaining weight? How are they feeding throughout the day on a 24-hour cycle? They can't sleep at night, they're snoring, they're grunting, they're making lots of noises, they have terrible reflux, they're miserable, you can hear them swallowing air when they're feeding. And that actually, it doesn't stop in infancy. A lot of these things continue as the children grow and develop. And then you see them. You see them as, toddlers, older children with speech issues, articulation disorders, feeding disorders, oral myofunctional disorders, tongue thrusting, all of these little pieces of the puzzle that we're all trying to get a handle on and put together. It's very difficult. I have a difficult time because half the time I'm getting them from maybe a source that is still in their silo and is looking at things in, one way, and it's very difficult to assemble the team. So when we talk about outliers or we talk about regions where we are, we're all trying to assemble teams of people that we can work with because it is a team approach. It really takes a village. What is a tongue tie? There's differing definitions, and there's actually a very recent paper that I'm going to share with you here that kind of has dispelled, what we think a tongue tie is. But the IATP, which is the International Affiliation of Tongue-Tie Professionals, defines it as the embryologic remnant of tissue in the midline of the undersurface of the tongue and the floor of the mouth. And we kind of talk about a tie as more of not just a piece of anatomy, but how it's affecting function. So that little string under your tongue, or if you have them, there's basically 7 spots that we kind of screen for at this point for restrictions or tethers or ties. And those are being the upper lip, the cheeks on both sides, also known as buccal ties. We look at the lower lip, we look at the lower cheeks. So those are 6 of the spots, and then you have the grand finale of the tongue. And that's what we look at as a general, screening area. The theories on these things is that we all have these kind of little webs and ties during embryologic growth and development. And there was a theory put forth by Isabella Knox, who was a neonatologist, and I think it was in 2010 she put that out, saying that there's incomplete dissolving or cell apoptosis, cell death of these, frenulums or restrictions, and you're left with remnants, and they can be in different locations. And interestingly enough, we all thought this was like a distinct piece of anatomy, like a band. It looks like a band, or it looks like a cord. There was a pediatric ENT, Nikki Mills from New Zealand, who I've lectured with in Australia, and she spent the day in my office, a couple of years back, sharing her research. She was working on a PhD in in anatomy, in microanatomy. And in 2019, she published that what we've been thinking about as ties or a tongue tie is actually not a separate piece of anatomy or a separate collagen band, but it's actually fascia. And she looked at the microscopic anatomy of frenulums in cadavers, in baby cadavers, kind of a little gory and gruesome. But what she looked at under the microscope is that the overlying mucosa, or the skin inside your mouth, is directly attached to this fascia. And all the tie is basically like a lingual frenulum is a fold of fascia, not a band. And that kind of, put a little bit of a spin on what we've all been learning and thinking about, because what she put out there kind of discredited some of the classification systems that we're using at this point, like Larry Kotlow's classification system and Carrillo's classification system, talking about these little bands or attachments. It doesn't make much of a difference, actually, on how we treat them, because what I termed to her is like, well, essentially then we're just releasing fascia. We're still doing the same procedure to release the tension and tightness to give full function to these kids. But not only the function, we're trying to affect structural growth and development. Because as you saw in Sydney's case or other cases that Dr. Avis presented before, these areas of soft tissue can cause issues with growth and development of the face, the airway, and when we look at soft tissue versus bone, we find that the soft tissue pulls and these areas of pressure or non-pressure affect growth and development. So the soft tissue always seems to win when it's fighting against the bone. Understanding what's normal, what's not normal, I still don't know. I still don't know what a normal appearing. I asked some colleagues, can you send me slides of what a normal tie looks like? I have, one of my mentors, Kathy Jenna, who I do research with, who's a very, famous lactation consultant, feeding, swallowing person. She sent me one of a baby that, didn't really appear to have much of a frenulum, and the tongue was, just resting on the roof of the mouth. I hardly ever see that, I have a biased practice, of course, because most people are coming to see me that have issues and problems. But trying to get an understanding of incidence and numbers out there is difficult for us at this point. The literature kind of pre-breastfeeding rates on the rise, which in the past decade, if you look at literature rate, with breastfeeding rates, they've been climbing steadily. Quotes anywhere from, I think it's, 0.04 to maybe up to 12% of the population has, a noticeable tie in the mouth. Whether or not it needs treatment, we don't know. There's more recent studies looking at ties. And interestingly enough, when you look worldwide at, screening, how do these things get screened? There's no uniform classification system. There's no uniform screening way to do this. Brazil, interestingly enough, has this as a national law. So babies cannot leave the hospital until they are screened and treated, and there's a protocol. And that was developed by Irene Marchesson and Roberta Martinelli, who are speech therapists, oral myofunctional therapists, and they help craft specific validated guidelines on screening babies. They also can screen older kids up through adults from a functional and anatomic standpoint. And that can help you with your decision making as far as, does this person need a release or not. They found, in their study that they looked at the posterior tongue tie, which is, what is that? We'll show some slides of maybe what it is. We talk about these things in general terms, so I try to really kind of keep things simple. As a surgeon, I got to keep it simple for myself, and I always use that rule of KISS, K-I-S-S, keep it simple, stupid. Because we get into these classification systems, you're looking at all of these numbers, how much free range of motion do you have and whatever. It's like, what's going on with you? Tell me what you feel. Tell me what you think is going on with your child. Tell me, like Dr. Avis said, it's like, you got to listen to these people. They're telling you the diagnosis, telling you something's wrong. My instincts are kicking in, something's wrong with my child. We can look at numbers, you can look at statistics. We see an increasing number of patients coming in. Doesn't mean that there's increasing numbers growing, but there may be. And there may be epigenetic forces, there may be changes in our diets and whatnot that are affecting these things. But some of the research that it was showed maybe up to maybe 30% or maybe 30-something% of the population has a tie that is affecting some form of function under the tongue. So kind of getting back to where we are and what I talk about for today, because I can talk about feeding and I go on because that's really where I started. Airways kind of came into my practice in the past 8 years. I don't do bony work at this point. I trained in doing maxillomandibular advancements, orthodontic surgery, all of this other stuff, and I've gotten away. So in my field, I am an outlier, and I treat tethers, and that's really kind of what I do at this point. And the need for that has been tremendous. So it's probably about 90–95% of my practice at this point. And when we look at this and you start to look at the research and you collaborate and you put all of these pieces of the puzzle together, this could be a potential significant piece of a puzzle. Not always the silver bullet, but it's a piece. So we need to work as teams and collaborate. And when you go back to how these little tethers in the mouth are affecting growth and development, as I said before, when you look at the battle of soft tissue versus bone, the soft tissue always wins. And that tends to lead to orofacial and airway collapse.